smoldering kind of effect of endophthalmitis. That slowly take away your iris, it gets denatured, decolored, and then the pupil gets a different shape, and the patient is not happy with the vision and slowly deteriorating vision, some edema in the macula. So that kind of endophthalmitis is also there. One has to keep that thing in mind. And I've seen people taking out intraocular lenses and then washing again, and then this thing settles because some kind of bacteria, they settle in the capsule and they are immune to medicine that we usually use.
What about you, Zubeda? Any
thank you so
regarding
much,
the
Prof.
symptoms and signs?
So reduced vision and pain are the most important symptoms according to the AVS study. Those were the most 95% of the patients. Those were the common symptoms. Apart from that, next involvement would be there, like the eyelid swelling, and eye would be red, of course, and fibrinous membrane would be formed if the patient is presenting within a week or so. So those are the symptoms.
I think TAS and endophthalmitis, that again people do confuse that either, and sometimes we don't want to accept that we have endophthalmitis. So we try to keep ourselves pushing. It would be. I would like to welcome Dr. Safdar Raja. He's a bit late, but he's one of the panelists. Come, Jenny, please have a seat. So, how would you differentiate between TAS and endophthalmitis, Rahman?
I think one of the features, first of the things that it's quite challenging, and as you said that if it's your own case, you tend to kind of think that hopefully it's going to be TAS, not endophthalmitis. And if it's someone else's case, you might treat differently. You'll be more aggressive, particularly if it's referred to VR, tap and inject, and maybe even thinking about doing a vitrectomy. I think what I've found very useful is if a patient comes to you in the clinic with symptoms that you're thinking maybe it's TAS, maybe it's endophthalmitis, particularly if you have used things like, that are known to cause these issues for constricting the pupil, stuff. So the important thing is that give them some drops in the clinic and observe them. Because both patients will have hypopyon, both patients may have corneal edema, both patients will have pain, all those things. And the bookish thing that, tells you about limbus to limbus cornea, I have not seen in all the patients, and sometimes you're taken by surprise. So one of the things that I have found very helpful is that if you have a patient, say you have seen the patient 10 o'clock in the clinic, and you think that this may be a TAS, don't send the patient home. Start giving intense drops, for example, PrEP 40 drops in the clinic, dilate the pupil, get them to wait. You can do a B-scan ultrasound, but then see the patient in a couple of hours. If the pain has improved, if the hypopyon is going away, that is a good sign that this is TAS. Just see them the next day. But if you've seen the patient after a couple of hours and they're still in the same agony, and hypopyon is there or maybe even worse, I think this is a clear-cut sign that this is endophthalmitis. You really need to tap and inject the same thing.
Dr. Safdar, would you like to add something? TAS and endophthalmitis comparison and how you can differentiate?
Sorry, I'm late to the party here. So you're discussing.
So talking about endophthalmitis panel discussion we are doing. Initially we discussed symptoms. Now
as the panelist has basically said, you need to make sure you need
I
to
think
make.
Gustavo is hearing us well, so he's getting difficult. He's operating as well. Yeah. Gustavo, are you operating or are you watching your fellow?
No, I'm listening to you. I'm learning a lot. Keep it going.
Is he,
Okay.
Is he on the lunar module?
No,
is he on the lunar module Al-Qamar or something? I think it's important is that as you need to act very quickly. Obviously, the duration of how they present gives you some idea of how it's going to be. And in that you have to keep them in the clinic. It's a Friday afternoon heart sinker for us. When it comes through, you have to sit with them, and the first on call has to sit with them. Registrar has to do the job, and you wait for the pupil to get bigger and see how things are basically. But I think the timeline, the durations are of course very, very different for how do you. We have not had a post-cataract endophthalmitis since 2008.
Since 2008?
Since following the AICO study. We don't do a lot of cataracts. We only do about 3,500 a year. So that's not a huge number.
Yeah,
like a medium level unit. I did an audit of that pre-2008 when we sort of looked at about 10,000 cases.
Right.
And our rate was, I think it was acceptable at the time, about 1 in 600 for that time, an era. But since the AICO study had the shift of using intracameral cefuroxime. We've not had any issues. Intravitreal injection post-op endophthalmitis, that is different. We do get that, but our rate is about 1 in a 5,000 injections. So it's pretty good. So.
Ahmed, do you think there is a role of B-scan in differentiating between TAS and endophthalmitis?
Yes, of course. I do B-scan for all cases of TAS. If I suspect TAS, I do B-scan. Of course, the onset is important also. TAS usually happen in the first or the second day. Endophthalmitis usually in the third day. It may happen earlier with aggressive organisms like staph or and Pseudomonas. I dilate the pupil and I check the red reflex of the slit lamp. If I see a good red reflex and I do B-scan, there is no vitritis, most probably is TAS.
Yeah, I think that's important thing that usually you won't have vitreous activity in. Dr. Tariq, you want to add something?
Nothing else to add, to be honest, but the thing is that, as the gentleman just said, if you can see the fundus clearly, it's a sigh of relief. But if you see the fundus a little bit muddy, is the activity in the vitreous, that's a warning sign. And in the follow-up, if you cannot see, if the fundus is worse, this is the time straight away to refer to the VR surgeon. But you can try 2 injection, max 2 injection, not more than that. Max 2 injection you can try. If not, there's no need to be a hero or macho man. Just straightway refer to the VR surgeon. I think this is the best thing. But watch the fundus picture. If it is clear, it's a sigh of relief. If it's not clear, it's a very dangerous sign.
Gustavo, anything you want to add regarding TAS and endophthalmitis differentiation or any hallmarks?
Absolutely, I agree with our last colleague. Okay, B-scan, it's a must, because if you see that vitritis or the vitreous is hyperechoic, it's time to go for vitrectomy. Don't wait too much.
Yeah, thank you. I think pain-wise, it's a very relative thing, because we do see endophthalmitis cases, no pain at all, especially in the diabetics. So visual loss is really important. If your patient complains about that the vision has gone away, even if no pain, I think it's better to have a look. That will give you some relief. Because yesterday I did a list cataract, and this morning, or last night, my sister said that she's complaining she can't see much. So you start getting no pain, nothing else. So I asked her to come over. And it was basically straight. I already told her it was a very dense cataract. But at that time she was not much bothered with the vision, but later she told that I'm not seeing as good as I was seeing previously. So, yeah. Rahman, you want to add something?
Yes, I think one of the point is, duration can be anything.
Yeah.
I had a patient who was operated 3 months ago, and then he was away on a golf trip to Sri Lanka, where he realized that suddenly his vision dropped. And when he flew over to Karachi, I saw it, and he had hypopyon. And it's a culture positive endophthalmitis. I had to remove his IOL and bag and everything and implant it. So, my experience is that the longest I have seen so far is 3 months for an endophthalmitis. And the vision suddenly dropped to count fingers overnight.
Just have a comment,
Sorry,
comment
I have
on that,
also seen such patient. That is sometime a blood-borne infection that goes into the eye, and that also causes sometime. And the patient that I had seen, he had a severe UTI, and later he developed
And that was a post-cataract?
No, not post-cataract. Just developed
Endogenous,
out of the
you're
blue.
talking, endogenous, okay.
Yeah, like the one he has seen. So it's sometimes blood-borne infection. It's rare. And the other thing between TAS and endophthalmitis, I don't know, it's my hunch. If you look at the eye with endophthalmitis look sicker as compared to the TAS. The anterior chamber is slightly clearer, and it doesn't have that much of filamentary reaction as it is in endophthalmitis. And the iris color also looks little better than as in endophthalmitis.
Dr. Safdar, you want to?
Yeah, I think just a couple of comments on that. I think the time durations are important, especially people who are taking the fellowship exams, whether in Pakistan or in UK. The first 6 weeks is considered acute post-op endophthalmitis, and anything beyond 6 weeks is basically would be chronic and can present at 3 months, 6 months, 9 months, depending upon what the sort of the situation is. The other thing is, the other thing to consider is that if there's any problems with the concentrations of intracameral cefuroxime. If somebody had diluted it wrongly 10 times, you're going to get a massive macular edema. That's one thing to consider in mind. So the other bit is with vancomycin, you can get, if you're using intracameral vancomycin, very rarely patients can get this hemorrhagic occlusive retinal vasculitis oral kind of a thing. So that's
I
really
had one
easy.
patient, yeah.
So if in doubt, tap and inject and refer to a VR colleague, I think that's a safe bet to do.
So I think it's...
Just carrying on from what Dr.
Yeah,
Saab said, that,
yes.
the hunch of differentiating between the TAS and endophthalmitis is my thing is that I don't look at the eye, I look at the patient. If the patient is angry looking, it's likely to be endophthalmitis. If the patient is like, Dr. Saab, why you look so worried? I think that it's TAS.
It also depends if it's a
So one
private
of
paying
the-
or a government patient.
One of the other things
Yeah.
between TAS and endophthalmitis would be the time duration. According to the book, if the patient is presenting very early, like within 24 to 48 hours, we would be thinking about TAS more commonly.
So just moving forward, so I think interesting discussion going on. So can I have
I have got a very
photo of my presentation? Yes,
I've
Doctor.
got a very short presentation on this subject, which
Yes.
interact everybody, and it's not been offending
Sure,
against the VR
sure.
surgeons.
We will,
but
we can
definitely.
shortly do, that's. So, acute endophthalmitis, that's one of the chronic. So chronic means that things are going on for some time and it becomes quite angry. So you can see what's happening in the pupil, how vitreous will be looking, so it really gets worse. So bleb-related endophthalmitis, I think cataract, it's mostly bleb-related. Any peculiar thing that's important in bleb-related endophthalmitis? Dr. Safdar is, I think, wanted to comment.
Yeah, I think stay away from them,
Stay away.
That's what I would say.
That's
They're
good.
really nasty eyes in my
Yes.
experience. I mean, I don't do glaucoma, but I've managed them. And the problem with them is because they've been on drops for 20, 30 years, right? And their ocular surface is absolutely, completely knackered. So
Yes.
by the time they get to you and they come to this,
Yes.
I think probably they are your case, Amir, or probably any of the VR surgeons around here, they can tackle that. So-
Gustavo, can you see the slide there as well? So bleb-related endophthalmitis we are discussing. So
Yes, I can clearly see it.
Yes. So what would you do? You would send away the patient, or would you manage it? Because one of my colleagues, he's a retinal person. He said no, go area. So what would you do?
No, actually, I have no excuse because my middle brother is a glaucoma specialist. So, in such cases, it is him or myself.
Right.
I prefer usually he does it, but I am the retina guy. We are the firefighters in ophthalmology. So, in such situations, if you might have the chance to work together, it's the best chance. But these cases are super, how can I say? They are not as urgent, as post-fake or post-injection, because this case is as I can see, there is already, like I can say, our immunologic system already has kind of resistance to it because it has been dealing with these bacteria, and these cases, they developed, how can I say, slower. Of course, in surgeries, which is right after the trabeculectomy, it's different. But I have seen, like you were discussing before, chronic endophthalmitis. I've seen cases like this many years after the trabeculectomy, which have evolved to endophthalmitis.
Interesting. Yeah. Any other take from Dr. Tariq, please?
आई एम ग्लैड कि पीजीए का कोई बंदा नहीं बैठा हुआ ऑडियंस में, वरना भी झगड़ा हो जाता.
That's a Pakistan Glaucoma Association we are talking about. So.
And bleb-induced endophthalmitis, they're always very nasty. The good point is do not play with the bleb. If you see any cystic bleb in your routine OPD, tell the patient it can burst, it can infect. They should have a handy antibiotic drops to start with if thing goes wrong in the middle of the night, just to be at the safety thing, if thing goes wrong. Do not play with the bulb, just treat the endophthalmitis straight away.
And usually they are phakic as well with cataract, so that also makes, so you have to decide either phaco you are going to do or not. Rahman, what do you think?
That's
Phaco would you do, or in such case, or you would try to avoid it, or if you are getting a decent view, what would you do?
I think the problem is, you really have to contain. So do the least amount of work to get the maximum benefit, and these patients usually have had the trabeculectomy done because their discs are usually 0.8 or 0.9 already. So you're not, doing, a lot of improvement in patients' quality of life, unless it's the only seeing eye. So I think, tap and inject. If you require vitrectomy, do vitrectomy, but minimize the work that you're doing, because I think everybody knows that these eyes are, do not perform well.
And that was quite young patient, and other eye and glaucoma as well, but quite young. He's in the pharmaceutical industry, but he did really well. I did vitrectomy in his case. Later we did cataract, put the lens, and he did well. Vision, I think, improved to 624 or something. Anyone else want to comment on bleb-related endophthalmitis or no? Okay. So yeah, that's another example. So coming to the post-intravitreal injections, I think which is more related to us all as medical retina or surgical retina, we all have to come across these situations. So that's the patient with hypopyon, with hazy cornea, and after 3-4 days of injection, not much pain, diabetic patient, but the vision went away significantly, and patient comes to you. So what would be your approach? Would it be the similar as you're dealing with the cataract surgery related endophthalmitis, or do you do something different in these cases? How would you initially start? Dr. Tariq, you want to comment?
Usually with the intravitreal injection, specifically with the disaster which had happened in Lahore, that was basically a supply chain issue. It's nothing to do with the surgeon, or it's nothing to do with the drug. It's very rare with the intravitreal injections, but it can happen.
Yes.
But it happened, then you have to deal with it intensively, and make sure that you're putting the patient is putting the drop post injection, and she's following the instruction correctly. But if anything goes wrong soon after that, she should come back, or he or she should come back to you straight away and deal with it as a routine endophthalmitis case.
And you start with the injections first, intravitreal antibiotics, or
yes,
would you go?
We pre-operatively we do put antibiotic in the theater with the Alkane and all that, and we also follow the drops at least 3-4 times a day for 3 days at least.
Right.
We normally do that. I think it's the same practice in England as well. I think you do most of the intravitreal here.
Are you guys using antibiotics post injection, Dr. Safdar?
No, we don't.
No, not anymore now. Yeah.
There's been a
Even
number
no
of-
pre-op, no post-op either.
There's
Huh?
a number of years. I think by the time the patient comes here, the horse is, as they say, already bolted. It's too late. So you have to treat it whatever you can get your hands on. I think that the battle you can win is well before that. And identify the risk factors, and you're not going to go through them like nephritis and stuff like that. But patients even in UK do very funny things. They will rub the eyes, and the little old ladies, they're fascinating in my area where I work, and they do all sorts of things. I've even sort of patients don't like the drapes. I've sort of even injected people just with they don't want iodine. So I think the crucial bit is really the 5% per iodine. I think that's the crucial bit. If it sticks on the eye for about 2 minutes or so, 90 seconds, I think that's pretty much good enough. If they are clearly allergic to that, they develop a sensitivity to that, you can try chlorhexidine. I think it's available now in 0.1% or 0.02%. That's available as well. We have a completely nurse-led delivered or nurse-delivered injection service for the last, I would say, 10-12 years now. We do about 8,000 injections a year for various nice indicated indications now. One thing about intravitreals is that I do remember the steroids. They have a high risk of endophthalmitis, so you have to be a bit more careful and counsel and consent the patient accordingly. And you can probably, it's an exam question as well. If I'm your examiner, I'm going to ask you that whoever is sitting here. So these are the little sort of things. But I think in view of the management of endophthalmitis, I don't think there's going to be much variation. Post-operatively, we don't use the drops anymore.
Still suggest first injections. No need for going directly to vitrectomy, and just do intravitreal antibiotics first.
Yeah, I know.
And then if it doesn't improve, then refer to your colleague.
I know the moderator is a VR surgeon, but medical retina people have their uses as well, I suppose. I think it depends on the level of vision.
Yes.
Only eye, what is the status of the other eye, and patient's lifestyle as well.
Yeah, but I think approach is similar as we're talking about. Intravitreal antibiotics, the first thing you need to.
I think it's if you know how to put in a trocar and a 23 gauge cutter, you can get a very nice sample as well. I used to do VR once upon a time, but I don't do it anymore.
Dr. Ahmed, what about you? Prophylactic, do you give antibiotics pre-op, post-op? What happens in Egypt?
Yeah, we know that antibiotics pre-operatively or post-operatively does not have any role. Even it may increase the resistance of the organism to antibiotics. But
So
in
you
Egypt
don't
we
use
give
any antibiotics?
no,
after-
but in Egypt we give because
You
I'm
do
afraid.
give. How many days? How many days?
Yeah,
How-
for 5 days.
5 days.
Because I'm afraid that if the patient developed endophthalmitis, you might tell me,
Yes.
you didn't give me an antibiotic, that's why I got an endophthalmitis.
Somebody is going to sue you if not given antibiotics.
So I give antibiotics pre-operatively and post-operatively.
Gustavo, what about you in Brazil? Do you give prophylactic antibiotics pre-injection or post-injection?
So I was laughing together with Rashdi because when I started, of course, I would give drops for 5-7 days, and patients feel safer when you give them drops. When the paper showing that not giving antibiotics was safer than giving them, I stopped use. I had so many patients wanting a consultation with me to explain why I was not giving them drops. So I had to explain the paper for my patients. It took me like half a year to convince them that they didn't need the drops. Nowadays, we don't use anything. The only prophylaxis we do is iodine povidone 30 seconds before the injection, or at least the region where we are going to inject, okay? And since then, hopefully we haven't had any infection, but you have shown us an extreme case, okay? Since the entrance spot compared with the phaco, it's much smaller, you don't have the same charge of bacteria, okay? But usually you can solve it with injections. You don't have to go to vitrectomy. And I think it works perfectly. One issue we have here, it's a big concern. Most of my patients come from, or at least half of the patients, live like 200 or 300 kilometers apart from our clinic. And these patients, of course, you have to inject both eyes, okay? So never from the same vial, okay? Otherwise, if you have an accident like that on both eyes, it will be a disaster.
Yeah, that's I think true. Yeah.
And you can also, you cannot also make this patient come every 15 days because it's too expensive for them.
Yes. Yeah. Rahman, you want to add, or Zubaida?
I was just going to say that I use the antibiotics as a lubricant. So, a lot of patients have complained with the povidone iodine because the eye is irritable. So I give them 4 times a day, and if they complain, I tell them already that, agar aapke aankh mein problem ho raha ho, just use it every hour.
Okay.
And it's more
And
as
just
a
for
lubrication.
4-5 days you do?
Yes, 4-5 days.
But no pre-op, you don't
No,
use.
I
Because
don't
some
use
people still
anything.
use, and I know the colleagues who use tablets as well.
Yes,
Oral
yes.
antibiotics, people are
Yes,
still
yes.
using
so
it.
every month they take oral antibiotic course, and then they
Yes.
take drops course. But
Yeah.
I just use it as a psychological thing, as in Egypt. So I don't want to be blamed that for not giving antibiotic, they have any problem. And mostly it's actually preservative-free antibiotics such as moxifloxacin. So if they have a problem, they can use it as a lubricant as well.
Zubaida?
Thank you, Dr. Aman. So in Dublin, where I was being trained, they would give pyridine prior to giving injection, like while the patients were waiting in the clinic. We'll just put 1 drop of pyridine along with moxifloxacin, 1 drop, and there were a few consultants who would insist on giving, post intravitreal injection antibiotic as well for 4-5 days. And another comment I would like to add is there have been studies which show that the culture, mostly in the post intravitreal endophthalmitis, the culture would be streptococci. There's the aerosolized flora, the mouth flora. So we really need to, cover our face before giving injection.
I think it's a very important point to wear the mask. Absolutely. So that's important thing. I think caps and other things may not, but mask is that right? Mask is even in UK, or you don't wear masks?
I think mask is an interesting one because we used to wear that and then we
Yes.
stopped it altogether for many years.
Yes.
And then COVID came and we went back to the mask now,
Yes.
and then it started to come
Yeah.
off again. So it's a bit of that. Well, I think there was a study from John Hopkins or somewhere about a few years back where they showed that if you speak, I think that the proper culture of the agar place and all of that stuff, they did that. I don't know how sort of if you properly critique the study, whether how valid is that, but they actually showed, and there are a very huge number of patients in there, that actually if the minimum amount of speaking used during the injection, that is what matters. So you shouldn't really be saying, and we used to chat with our patients all the time, you know, so, but our rates were no different. So I don't know what there must be something in the air everywhere different, you know, and how it works, I suppose. But the mask is purely because I think it's a COVID legacy now over there, rather than purely needing it from the injection point of view. And even now, the cataract surgery as well, we are trying to move away from that now.
So traumatic endophthalmitis, I think, let's move. Sorry, you want to add, Dr. Shakaib? about something?
I think I'm the one you were mentioning that there's some doctor who are still using tablets also. So
Oh, sorry, I didn't know that.
because I'm not, I don't play brave
No,
in
but I
this
know.
thing.
Yeah.
So my practice is that when the patient comes to me for at least 15 minutes, every 5 minutes or 4 minutes, he gets a drop of antibiotic in the waiting room, drops. And then some local, proparacaine, and then I inject under the microscope in the operating theatre. And then I give one 500 milligrams ciproxin an hour before and one, say, after 12 hours. I tell him take 2 tablets, one before and one after. And I also give antibiotic drops for a few days, antibiotics and steroid combination for a few days. Just follow. And so I don't play very brave in our situations because
No, but
Do you have any shares in the antibiotic industry or not? No?
with this approximate.
I know some people who give for 1 week tablets.
I think Hina wanted to say something.
Yes, Hina, please.
When you have a post-injection,
A mic to दें kindly, Doctor Sahab. I think it would be better everybody can hear.
I would assume I'm loud enough. Thank you.
No, you are not loud.
So when you have post-injection, and there are studies to back this up, that it's actually more florid and more aggressive because the portal of entry that is now sealed, it just leads to more of, nastiness within the vitreous cavity. So I do also have a low threshold of taking this patient to my VR surgeon for a vitrectomy because most of these patients enjoy, relatively good vision. And when they're left with those kind of floaters, that even if you treat with intravitreal antibiotics, they're left with that kind of floaters, and they're very, very annoying patients to come back to you. They keep coming back to you कि ये तो मुझे पहले नज़र नहीं आते थे. तो अब आप उसको कैसे समझाओ कि भाई जहाँ से आपको वापस लेके आए हैं, जहाँ आप जा रहे थे, तो वहाँ भी अल्लाह का बड़ा कर देता हूँ, but that floaters, they stay, and therefore the patient stays in your clinic. And so if I have to go, because of the aggressiveness of the disease, I do have a lower threshold. So I've had one endophthalmitis, acute post-injection endophthalmitis case in 6 or 7 years. I will not advocate not using antibiotics, even though we won't have enough evidence of that. But if we do have evidence
You mean
of
topical or
topical antibiotics in Pakistan, because if we are to swab our OTs and to swab our the commensals in our patients and swab everything else, what I do, and I feel like is a good trick, is and what I learned from my consultant in the UK was, if you just retract the conjunctiva before you inject, so as the conjunctiva goes back, it kind of forms a natural bandage, natural barrier to your site of entry actually, and it gives like a longer route for the commensals to actually reach the vitreous cavity, and I think that really helps. Povidone iodine really helps. Everyone has different time. Mine is about 45 to 50 seconds, and plus there is installation of house-trained povidone iodine while the patient is being ushered into the OT and doing that list, and I think that really helps. So there was that outbreak in Tennessee, I think that's the one you were talking about 4 endophthalmitis cases, and they traced it back to the dispenser in the pharmacy not wearing a mask and talking to his colleague while he was preparing the injection. So there is evidence. I don't know, I haven't critiqued that article yet, but that was the conclusion to that article. So yes, I do advocate everybody in my OT should be wearing a mask.
In our circumstances, yes, I
Yeah,
agree.
I think it is, yeah. But traumatic
I think it's,
endophthalmitis.
I think that is an important point, but when you are doing your injections, I think there is a specification of your operating room or a clean office. I think there has to be a certain number of air exchanges. I think the minimum for intravitreal injection in UK is 10 airflow exchanges. For a cataract operation, it should not be less than 25. So I think as long as you got that airflow exchange and everybody else is behaving, that should be okay.
Any one of us doing in office injections here? In office means in your clinical room, जहाँ patient को देखा है, you're injecting. Clean room is different thing. What I'm talking in office means that you examine the patient in the same room. I think US people do. Anyone in Pakistan does, Gustavo, and in office injections, or do you do in clean room or theater?
No, in Brazil it's forbidden. You have to do in the OP room.
Same.
It's a pity because you lose a lot of time and increases the costs. Okay, so you have to take a whole morning or a whole afternoon to do the injections. And I think our offices are clean enough and safe enough to do the injections inside it.
Right. Okay. I think
Yeah,
in
I think, Amir, it's, I look at it by the way is do a mother test and a mother-in-law test. If my mother is getting injected, I want a clean office. And my mother-in-law, I don't care. You know, so I think that's an easy way to remember.
Interesting. Okay. Traumatic endophthalmitis. I think, Rahman, if patient comes to you, there is a trauma, maybe not intraocular foreign body, some thorn went into the eye or something happened. Patient comes like that. Can we have the photo there if somebody hasn't missed? So how would you proceed with that case, Rahman?
So I think
Injections, vitrectomy, what would you do?
well, again, I would try and start with injections, depending on the situation of the eye. But when you move from post-cataract to bleb-related to traumatic endophthalmitis, these are the severest. And
Yes.
you kind of tell the patient with trauma, particularly with the foreign body, there's a 1 in 10 chance of developing endophthalmitis. And usually it's not just one thing, there may be something else. There may be a foreign body, there may be traumatic detachment and things like that. So you really have to explain, and the visual potential is not very high. So you have to counsel the patient, and usually it's the family because these are kids. So you have to explain
Usually
to
they are
them,
young people, get
patient.
trauma, So your take would be first injections you would like to
I would
try.
again, because one of the reasons is that if they are kids, you really want the vitreous to separate before you actually take them to OR. So, you treat them with injections until the vitreous separates, and then you take them to OR.
Yes. What about you, Ahmed? What
The issue in these cases is that the cornea worsen quickly. So if you inject them, what about the cornea? Usually it worsens very quickly. That's why I proceed with vitrectomy.
So you would go for vitrectomy earlier in trauma
In
cases?
this case, with a
Yes.
good cornea, I will go.
Yes.
I want to go with vitrectomy with this good cornea. I
Gustavo,
don't
what
want
about
to
you?
lose a good cornea.
Traumatic endophthalmitis, would you inject first or would you go for vitrectomy?
So that's a very good question because this is very seasonal here. Since the region where we live, we have a lot of people who still work on the field, on the rural area, okay? April is the month of traumatic cases, eye traumas, because they start to chop wood for the winter, which in the southern hemisphere is in June and July, okay? So, and it's almost automatically here. In this case, it's vitrectomy for sure.
So vitrectomy you would go for, okay.
So I would just like to add a comment. I had a patient with traumatic endophthalmitis. He presented with counting finger with blunt trauma, traumatic related cataract, and very, very bad endophthalmitis. What I did was, instead of, because he couldn't go to bigger cities because of the financial conditions, I started giving him intravitreal antibiotics along with DEXA. I really gave him frequent DEXA, and then I did the cataract on him, and his vision improved from counting finger to 612, and he's doing really well now. So he didn't need vitrectomy.
Okay, but most of these cases have fungal endophthalmitis. So a large number of traumatic cases have fungal. So I am worried to inject dexamethasone in the presence of fungal infection.
Yeah.
So if I going to inject, I would inject.
I think
antibiotics.
cause is also important.
Yeah,
What thing
cause is
happened?
important.
Trauma.
Here it was blunt trauma, so I wasn't being suspicious of the fungal one.
So, coming
Amir,
to
I'll
preventing
just
endophthalmitis.
Just
Sorry,
a
you want to
comment
add
on
something?
that,
Yeah.
on traumatic, any trauma basically is that they just remember the eyes are stuck to the body and not the other way around, is to make sure that look for sympathetic ophthalmia as well. It's rare, but you will get it.
Yes.
If you're not careful, I've seen a couple in Pakistan before I left for UK, and you will get it. So important, and other thing is tetanus prophylaxis as well. That's important as well.
Dr. Tariq, prevention of endophthalmitis in cataract surgery, what precaution do you take, or in your practice, what do you do to prevent endophthalmitis?
Before cataract surgery, we don't give any antibiotic, but the theater preparation is most crucial. We always give local anesthesia. We make sure, if we are doing under the tropical anesthesia, we make sure the bottle is clean. It hasn't been used in any other patient in the OPD or elsewhere. It should stay in the theater, number one. Number two, a proper cleaning of 5% pyridine iodine is more than enough if you can do it properly. But in my experience, by mistake, we have using 10% pyridine iodine. It doesn't happen to the eye anything. Even we have seen it is more safe than 5%. You can use it. And
So you're using 5% pyridine to clean it, yeah?
yeah.
Okay.
Yes,
You
but
mix it and use
by mistake, we have used 10% as well.
Right.
It also works as good as 5%, doesn't matter. But you can make your own 5% with the 50-50 solution with BSS you can put in, वो जो pyridine जो आती है यहाँ पे. The thing is that with proper cleaning and make sure that your lid examination, the retinal marginal disease, lid disease is there or not, that is very, very crucial before you book the patient for the list. These are the important steps. If you do this properly, if you put the proper drape on it, the lashes are covered, proper handling of the speculum, I think you are safe. If you're not doing these following things, you are in trouble.
Dr. Safdar, anything you want to add more, or
Yeah,
is it 5% do you use or 10%?
yeah, we use 5%.
5%.
A couple of my
diluted.
colleagues do a bit of a periocular scrub with 10%.
I think periocular usually I use 10%.
Yeah, but I wouldn't use it.
internally in SAC I use 5%.
Yeah, I think it's a bit not so. It's a bit 5% nicer to the cornea in some ways, you know. So, I think the battle is really won before the day of the operation. That's the absolute key to preventing. We can't prevent it 100%, but as I said, we have not had an issue since 2008. And now there's a wood to touch here. You know, you never know what happens when you go back. I think the key bit is we do run pre-op assessment clinics over there, which we always encourage our registrars to do. I found it very useful. I trained for 4 years in Northwest, and I did that sort of twice a week. Is to pick out those high-risk patients or immunocompromised patients that you think are likely going to go that route. I think that's an important bit, especially with ocular surface disease, as Professor Saab has mentioned. That's important. You know, aggressive diabetes, all the other stuff that can make that's really important. You've got patients with rheumatoid arthritis, immunosuppressants, so all these little things are important. If you know there's a complex case, don't give it to your registrar you don't like, you know, try to do it yourself. You know, these sort of little things do matter. And then obviously on the day of the operation, meticulous prep and iodine and all of that use. Since we have shifted to intracameral use, we've not had any issues really. So
I think that was one of the turning point, isn't it?
It was the ASCRS study by Peter Berry and Pierre Montan. I think that they did in 2008. It came out in 2007 and then completely changed everything. But that was the combination of 5% iodine with intracameral cefuroxime. If your patients say they're really allergic to or hypersensitive to penicillins or cephalosporins, then you can try vancomycin. We use vancomycin, but I think USA moxifloxacin is used as well.
We are using moxifloxacin.
So there's some people actually use a combination of cefuroxime and ampicillin as well. All sort of the only thing with vancomycin is you inject it inside the eye, the cornea goes completely hazy. So don't get too alarmed by that. It just goes away after half an hour. So.
Dr. Ahmed, what about you? Sorry.
For me, for cataract surgery, I think one of the most important factors for endophthalmitis is the leaky incision. So I spend a lot of time at the end of the surgery, make sure that my incision is tight, and I have very low threshold for placing a suture. I'm not shy at all to place a suture in the incision.
I think it's very important step that
so,
wound shouldn't be leaking. So
yes,
that's and I think that was the reason even when 25 and 27 gauge vitrectomies were coming initially, there were a lot of cases of endophthalmitis because not the wounds were leaking, there was infection. So wound construction is important and closure is important. Yeah, Rahman, sorry, Dr. Tariq, you want to add something?
Yes, I just wanted to ask one question to Safdar. इनसे हमारी जंग चलती रहती है अपने फोरम पे. You mentioned about the diabetes thing in Pakistan. The Rahman has published a very good article about the incidence of Pakistani diabetes, which is a very alarming pictures. Every other third patient is a diabetic in our society, and किसी की भी sugar control नहीं होती. You know, if we do the HbA1c, किसी का 8 है, किसी का 9 है. So in my experience, we don't consider diabetes as a major factor in endophthalmitis. यहाँ पे every other patient is a diabetic. And you said that diabetes consideration, it surprises me.
I think it's, I deal with diabetes all the time, every day. I think it's, the diabetics were really 20, 22 millimoles per above. I think that's the one that you need to target. I think the Royal College guideline is probably going to be changing next year on this as well, because there's a lot of confusion regarding the nurses are sticking in needles every time the patient comes in. So we have a threshold of about 20 on the day, but if the hemoglobin A1C has been quite poor over the previous few months, that patient is at a slightly higher risk. What I do is I tend to operate on them myself rather than offer them to my registrars or as a training case. So I think that's what I tend to do. But you're absolutely right about that. Diabetes itself per se is not a huge issue, but really these are bad uncontrolled diabetics who are really spiking very high. They are the ones to be worried about. The other thing is they've got comorbidities. They can have other issues. Renal problem is very common with them, liver problems. I've seen a lot of case mixture. The ones we have actually gone bad, if you look back at them, there's always a bit of an element of comorbidity that you pick out from these cases.
Gustavo, what do you use as intracameral antibiotic? Moxifloxacin or ceforaxime? What do you use?
Endophthalmitis is a so serious condition, okay, that when our fellows start doing their program here with us, the first presentation, the first lecture, the first thing we teach them, it's about how to properly prepare an eye for an eye surgery, okay? So 10% iodine for the periocular and 5% for the eye drop for the surface, okay? And since we had the paper that came out that the number was 2 million or 5 million eyes showing how safe moxifloxacin is intracamerular, we are using at the end of each phaco, we are injecting moxifloxacin. One issue about the comorbidities we were talking about, for me, the worst scenario is always diabetes. In my whole life, I had 2 cases of endophthalmitis after vitrectomy, okay? One was a patient which had his HbA1c, it was like 14%. He already had kidney problems, whatever. And the other patient had endophthalmitis after oil removal. That's something we are still registering. I don't know if any one of you have ever heard about it. But I was super disappointed because it was a very difficult retinal detachment. I could reattach the retina, used silicone oil. We waited like 4 months to remove it. And the day before the removal, he came with a super endophthalmitis, which evolved to phthisis. So it's an issue, but for general cases, phaco, if you are talking moxifloxacin, 0.1 pure at the end of the surgery, 0.1 cc.
Yeah, okay. Any, Zubeda?
So I'm not sure what is the consensus on intracameral ceforaxime versus moxifloxacin, but I just came across this paper that is being done at Aravind Eye Hospital, India. It's an ongoing study on like 2 million eyes, and they have seen very promising results with intracameral moxifloxacin.
Yeah.
I myself use intracameral ceforaxime.
Yeah, it's pretty safe, yeah. Dr. Shakaib, you want to add something? Or?
It's I give, for cataract patients also, I give prophylactically, I do give oral antibiotics.
आपके शेयर है लगता है अब तो साबित हो गया अब तो
I haven't definitely
Stock market आपकी वजह से ऊपर जा रही है.
exactly it's because of
Shakaib
that.
has got share in the company.
But on the other side, I kill them because then I don't have to use later on a lot of antibiotics, because if you do in Pakistan setting, it's always good because you never know they are harboring some infection somewhere or not. We can't test them, but somehow I do it.
Yeah.
It's my habit to a day before, on the day of surgery and day after.
आपकी सारी
I
एंटीबायोटिक
give-
छुपा देंगे हम.
Yeah, exactly. And same before the surgery, I don't start antibiotics a few days earlier, but on the day of the surgery, for about 10, 20 or 15 minutes while the patient is waiting for the first patient to come out of the theater. At that time, 15, 20 minutes antibiotic drops every 5, 6 minutes. So that gives a good concentration in the anterior chamber and in the sac. So, alhamdulillah, it's going good. So
Endophthalmitis is a huge topic. I think still a lot of things to, but I think I want 5 minutes to give to Dr. Tariq for his talk, so I'll just skip these things. I think mostly we have discussed about vitrectomy early later. So I'll leave the videos as well. So yeah, so just they were. Dr. Tariq, you want to comment?
This is a very interesting presentation, not offending anybody. Its topic is dealing with endophthalmitis. हो सकता है कुछ लोग offend हों इस presentation से, and post of okay, no problem. Okay, that's what. Indeed, it's the most feared complication, but if referred to you, do not blame him or her. यहाँ पे the most common thing is that if you refer this patient to another doctor, and the doctor will look at the endophthalmitis eye on the slit line, oh, although he's not saying anything, but that oh word, Doctor Sahab, meri aankh kharab ho gayi, that sort of a thing. One has to be very careful. Seek an opinion of colleague who you better equipped. Do not get irritated with the patient. If you think whoever you refer to a VR surgeon, make sure that he knows his job very well, particularly in this situation, endophthalmitis thing. And do not get irritated with the patient, because once endophthalmitis will have it, patient will ask you thousands and thousands of questions. No doubt about that. Keep all patient fully informed. Pessimism is better than unrealistic optimism. Refer to the VR surgeon you trust. The main thing is trust. I'm not offending any VR surgeon here. The thing is that make sure that you're referring to the patient, oh, tumhari to aankh kharab kar di is aadmi ne. The cataract surgery done in this part of the world. And no, I said don't be offended, the VR surgeon ko thoda sa pinch hoga, no doubt. And refer to the VR surgeon you trust, because
syndrome hai ye.
And the thing is that the VR surgeon should be better equipped to deal with this situation, because you're dealing with the vision, you're saving the eye, wanted to save the eye. If endophthalmitis happened, please don't charge additional fee on every visit. Okay? And refund the amount of IOL surgery if you have done it, because disaster can happen to anybody, although it's very rare. Because in this part of the world, in Asia and in India, Pakistan, Sri Lanka, the cataract surgery is the most common surgery done, and the complications will happen. VR procedure required cost. If you can waive it, or if the concerned surgeon can waive it, it will be a blessing, but it looks very highly unlikely. Express empathy with your endophthalmitis patient. Always talk to the patient. Please talk to the patient. Don't avoid the patient. Understand his or her frustration and fear. कि मेरी आँख चली गई, मुझे तो पहले तो मैं कुरान शरीफ पढ़ लेता था. I can read the letter, I can read the newspaper headlines. Now I can't read anything. To spend time with the patients. Don't get irritated. He will come to your OPD and he's sitting outside your OPD room every day or every week. Doctor Sahab, meri to aankh theek nahi ho rahi. That sort of a thing. Provide comfort, hope, but no false hope. If you think the eye is gone, better tell them. You're not going to see ever again. Because don't drag the patient again and again. Acha drop badal diya, agle hafte aana, nahi aana. Don't give any false hope. Stay calm. Stay calm. Give them as much information as possible. Do not get irritated, I am saying again and again to you. Calling you at odd times, because whoever's got endophthalmitis, he might call his friend somewhere in America. You might be sleeping at that time and you might be receiving call at that time because of the time difference. Receive the call, don't get irritated. Consistency is very important. These are the common questions the endophthalmitis patient will ask you. How, why, what can I do? You have to answer it. Be calm. how did this happen to my eye? What are the chances of visual recovery? Can you remove my eye? So these are the questions you have to answer it very carefully. Be sympathetic. Don't get irritated. Endophthalmitis, as we have all discussed with the wonderful discussion we had, and the moderator, Dr. You have conducted a wonderful session, no doubt about it. It's a very, very rare thing all over the world, and it's a serious matter, and it's a proper strategy with sensitive management. It is possible to emerge with your head held up and reputation untarnished. You have to be very careful. Thank you very much. Last thing I wanted to take 2 minutes. Medical Retina Association of Pakistan always give the leadership award to one of the budding people in medical retina. Hina Khan has received already this award from us, and today we are giving another award from our overseas member of our group, Dr. Safdar Raja, for his leadership qualities in the medical retina. Can I ask our sitting president of Medical Retina Association of Pakistan, Dr. Shakaib Anwar, to present this award to Raja Safdar?
Right. Just a comment, a couple of comments there. Thank you very much for the honor. Somebody has said budding after a very long time, so that's not I'm not gonna. Yeah, but budding is young. The other thing is that you put the rate of endophthalmitis as 1 in a 1300 to 1 in a 1700. I think it's a bit better than that, depending upon the cause. So, thank you.
आप साथ जाएं तो वो बडिंग लगेगा